Thank you very much. Assalamualaikum warahmatullahi wabarakatuh and good afternoon. The crowd is thinning, but still I see more than 20 people. My standard is very low. Less than 20, I go home. Okay, ladies and gentlemen, this is the last session. We have 3 panelists with us here. I will not read through their curriculum vitae because you have it in your folder, but allow me to say that Professor Yadav, Associate Professor Safura and myself, we are like a sandwich. When Dr. Yadav retired as the Director of Family Health in the Ministry of Health, I took over from him. And when I retired, Safura took over from me. So we're actually a sandwich here. And of course, the 3 of us, we had to run a program whose foundations were already very strong because the doyen of family health, family development, and maternal and child health is Dr. Raj Karim, who is here in the audience with us today. So we have a very good collection of people here. Professor Yadav will talk about some of the social determinants of health because there are too many. He can't possibly do that in 10 minutes. Safura will then take over and apply the social determinants of health in her work. And maybe, I suspect, she's going to cover only perhaps one group of the healthcare user or the client. And then the third speaker, Natasha, will speak about from the private sector because she represents an outfit called Doctor to You under the BP Healthcare, and she will talk to you how she leveraged care for the patient as far as the patient's social determinants or social well-being is concerned. And I have, 3 slides. Where are my slides? How do I get? Okay, I move this one here. Is it? I should have. Yeah. So I will use perhaps 2 minutes or 3 minutes of this. What are the social determinants of health? One of the directors of WHO whom I really loved and respected is the late Dr. J.W. Lee. He died in office and he did a wonderful thing. When he was in office in Geneva, he established what was called the Commission on the Social Determinants of Health. There was a report in the year 2005 that I was still in the Ministry of Health. It's one of my favorite reports of the WHO. And because of that, when I joined WHO in 2008, I conducted a bi-regional, that means Western Pacific region and Southeast Asia region. My friend and I, my friend from New Delhi, we met in Bali in 2009. It was a very exciting meeting. So we looked at the social determinants of health. We applied it to maternal health. And then we advise countries, how do you apply this in your respective countries? There are so many social determinants of health. Yadav will cover a few of them. It can be in the individual, in the family, in the community, especially in terms of values. It could be the health service. There's so many determinants. How to address these determinants? So the commission that was set up by Dr. Lee finished its work in 2009, and they came up with a report. The report is called Closing the Gap in a Generation, Health Equity Through Action on Social Determinants of Health. So they focus it on equity. This is what the report looks like. I know it's not very clear. Now, I would like to remind us that equity, do I have another slide before this? Oh, sorry. Equity can only be, what I'm trying to say is the SDG. So SDH is the social determinants of health. SDG, you all know, those are the Sustainable Development Goals, and we can only achieve equity or universal health access or universal health coverage. That's the sexiest word today, and we call it leaving nobody behind, leaving no one behind. And I would like you to look at the SDGs, or those of you in the health sector, you should know the 17 SDGs. The goal number 3 is the health goal, and in all of those, SDH plays a very important role, especially goal number 1, 2, 4, 5, and 6 are the social determinants of health. The other goals are also social determinants of health, including goal number 13, which is climate change. So, ladies and gentlemen, that gives you a background of what I have done in my work to look at SDH, and now Dr. Yadav, Dr. Safura, and Ms. Natasha will tell you their experience in applying the social determinants of health in their respective areas of work. Yadav, the floor is yours.
Thank you, Datuk Narimah. Actually, as Datuk said earlier, we are just one family. And I was in the ministry, but before that, I must say to Raj Karim, who has been the pioneer in the maternal and child health. And after that, a few years later, I took over from that division and Narimah, and then followed with Safura. So we are actually 3 or 4 of us here. I'd like to also, thank the organizers for calling me and asking me to say a few words on this social determinants of health, a very large topic. But I'll try to cover what I can within this time given to me. Also, the switching of gears, actually, because in the morning we have been so heavy, and then after lunch, again, finance, calculating figures, but this one is going to be lighter topic. So let me start by, before that, I'm going to start with, I'm getting a bit confused here. I'm going to start with the definition, WHO's definition. And in 1948, the definition, of course, says that the health is the state of complete physical, mental, and social well-being, and not merely the absence of disease. But all these years, we have been focusing on the physical aspect and very little on the mental and social aspect, which actually is one of the social determinants of health. And but we are also protected by this risk factor paradigm, which actually says the field of medicine operates under a risk factor paradigm, which actually we identify a characteristics or a risk factor that precedes a disease, and if that is statistically associated with that disease, then we look at the behavior modification for high-risk factors as the main strategy for preventing disease. So we look for risk factor, and the disease. But social determinants of health actually go beyond that, because social determinants are earlier than these risk factors. So, for example, if you take risk factors of smoking cessation, decreasing salt and fat intake in our diet, and sedentary lifestyle, these are factors which are risk factors to certain diseases. But if you look at this factor alone, they really don't cause disease, because smoking cessation itself has got precursors of risk factors earlier to that. Similarly as decreasing salt and fat diet, because it is related to nutrition. So because of this, we have what is known as the social determinants of health. WHO makes it very simple for us to say that social determinants of health actually is factors that we live, learn, work, and play. That makes it very simple. But if you look at the social determinants, it can be a large number of factors, which include socioeconomic status, poverty, housing, education, transportation, food, agriculture, social support, etc., etc. Now, if you look at medicine, very little focus is given to these areas, including even the training for medical staff, including the doctors who actually look in this. These areas are broader areas, and they, of course, say it's public health, but we need to really look into that. So if you look at this diagram, which I don't know whether you can see, the people are in the center, and that includes the age and the physical factors, age, sex, and whatever lifestyle we live in. And then we are related to the community. These are factors which are influencing our health. Then the local economy, the activities, built environment, housing, etc., the natural environment and the atmosphere, and then, of course, globalization and the global ecosystem. So we are influenced by these factors, a lot of these factors. And very little actually is being done into these areas in terms of health. So WHO defines social determinants of health as those factors that impact upon health and the well-being, and the circumstances in which we are born, we grow up, live, work, and age, including the health systems. And they are interrelated to each other. All these are interrelated. There's not like separate one of the other, but interrelated to each other, because lifestyle is related to environment and cultural, socioeconomic conditions which we are born, etc. And more importantly, the social determinants actually lead to health outcomes in terms of morbidity, mortality, life expectancy, and of course healthcare expenditure, health status, and other factors. So health outcomes are actually related to these social determinants of health. So these can be called as the causes of causes, because the fundamental cause of disease, if the risk factors are the precursors of disease, then the environmental and contextual factors that precede or shape these factors are the causes of causes, or these are known as the social determinants of health. And this social determinants of health varies from place to place, district to district, community to community, and so we have a situation of inequality in health, and that refers to differences in health status between different groups due to social determinants. In one area alone, it can be a different health status, and another area can be alone. And this is seen in this diagram. If you see in the United States, if you look at one of the communities, the Bennett community in North Dakota, the life expectancy is only 66.6, whereas in the neighboring county, the life expectancy is about 81.3. Very close by, yet there's a differences. And these differences are mainly because of the social determinants of health in those areas. Now, just a quick explanation on mortality and morbidity and the social determinants of health. You find that actually in terms of mortality, in terms of genetic, we are only 30% of them are in a genetic, mortality due to premature deaths. But behavior is 40%, healthcare is 10%, environmental exposure and social circumstances 45%. So if you add the behavioral aspect, the healthcare aspect, social circumstances and environment, about 60 to 70% of our premature deaths are actually due to social determinants of health, which very little focus is actually being given in the ministry and even otherwise. And adult deaths, if you look at adult deaths, a study was done in the United States quite some time back in the year 2000, about 845,000 deaths. Low education contributed to about 29%, racial segregation 21%, low socioeconomic support 19%, and poverty 16%. So, and income inequality about 14%. So these factors which you see, low education, segregation, and low support, social support, are factors which influence adult deaths. Similarly, in the child, social environment in children who experience multiple forms of abuse, witness domestic violence, and grow up in households, this is a social environment, where family members are mentally ill, substance abusers, sent to prison, actually they lead to 12 times more likely to have attempted suicide. Children who grow up in this type of environment, social environment. 7 times more likely to be alcoholic, and 10 times more likely to be drug abusers by the time they reach adulthood. And income inequality is one of the other big problems in terms of social determinants of health. And if you look at it, 1% of earners make 3 times what they did in 1980s. And bottom 50% earn the same average income they did in 1980s. So the rich are getting richer and the poor are getting poorer. And of course, that leads to actually in terms of care, medical care, and the income gap is widening. And if you look at this diagram, income inequality on the x-axis and the mental illness on the other side, if the highest in the United States, where the income inequality is very high, there is a mental illness also is very high compared to, say, in Japan. In Japan, there's income inequality is very low, so the mental illness is very low. So income equality plays a very important role in terms of health. Of course, in the middle you have some other countries like New Zealand and Canada and Hungary. Similarly, in terms of the burden of disease by income, again, income plays a very major role. If you look at the high-income countries and the low-income countries, just taking one example, I'm not taking all, 5 to 14 years old age, only about 4% of them contribute to the burden of disease in high-income countries. And this age group is very important in terms of the social determinants. Whereas in the low-income countries, they contribute to roughly about 31%. So much difference in terms of contribution of burden of disease by the young generation. This is partly due to the social determinants. Next one is education. In education, the higher your education, the lower the mortality. A study done by Wolf, mortality rates, he found that actually people who were less educated In this example, 654.4 per 100,000 for those who were less educated, compared to, if you look at the bottom one, 206 per 100,000 for adults aged 25 and 64 years with little education beyond high school. So if you are getting educated, the chances of mortality rate is lower as compared to that. The important thing is some of these problems are failure to identify the social challenges. In a study in Canada involving a survey of patients' care and social determinants, it was found that 40% of them reported that their family doctor was unaware of their struggles, because doctors really sometimes don't get involved in terms of the social, and they don't ask the social history. Even women were presented with bruises and broken bones, only 14% of them had asked about violence. This is, of course, one specific study, but it goes to show that actually it's very important to realize the importance of social challenges. Now, WHO has been working on this, as Dato' Narimah mentioned that she mentioned just now earlier also, a report closing the gap. I'm not going to go into that, but the point I want to make forward here is that the recognition of the fact that social determinants of health are very important in terms of mortality and morbidity in terms of disease. And so they are really, in the last 10 years, actually the WHO is working actively in this area. And this report, Closing the Gap Generation, identifies two broad areas. The first area is daily living conditions. We include healthy physical environments, fair employment, etc. And the second area is power, money, resources, equity, and health programs, etc. And following that, in 2011, the World Conference on Social Determinants of Health, delegations from 125 countries met in Rio to affirm the declaration that health inequities are unacceptable. I think that's a very important step forward, because WHO realized the importance of social determinants of health. And of course, citing in 2017, all the countries met again for the accountability. What have we done? Are we doing anything about it? And this is where I think Ministry of Health needs to work on this, some sort of a plan in terms of how to go about the social determinants. Finally, WHO recommended a framework. I'm not going to go into detail, but just to mention there's a framework for how to overcome the social determinants, socio-political context, governance, policies, values, social economic conditions, education, occupation, ethnicity, social class, gender, and of course intermediary determinants, material, circumstances, psychological factors, behavior, and finally the health systems. The health systems play a very important role in terms of training, etc. I won't go into the details of the rest because this is the same thing which I mentioned, but I just want to say, I think the important point I want to mention is the training of physicians, nurses, allied health sciences, allied workers need to address the social determinants of health, and physicians can better support patients with social challenges by asking their social history, providing them with advice, referring them to local support services, and facilitating. Many countries, example in Scotland and many other countries, are already addressing where the physicians actually know how to help these patients who need social support. That means they know the networking of social support and how to help them. And of course, social diagnosis and social prescribing involves connecting the patient to support services beyond the health sector. And finally, clinical practice guidelines. With that, ladies and gentlemen, thank you very much.
Thank you. Thank you, Prof. Yadav. By the way, Dr. Yadav is a professor of community medicine in MAHSA, and he could only cover in that very limited time on just education and income. There are many, many other determinants, but I think he has really focused it on those two. And the interventions he suggested was really daily living, lifestyle, and all that, and governance and politics. And I must tell you a personal experiences as well. Two of my most satisfying moments working for WHO is looking at religion in terms of health. And would you believe it? I had to talk to the church leaders in the Pacific Island countries. I turned them overnight, not really overnight. They did not want sex education in school. We good Catholics, we do not teach sex in school. And many years later, somebody from the South Pacific Island went to WHO and said in a meeting, intervened, when I went there in Fiji, he said it is against the God. It is against the will of God that we teach sex. And in Geneva, many years later, somebody from the Pacific Islands said, it is against the will of God not to do sex education. And I felt so good, because that was really a big challenge that I had to do with the Catholics in Pacific Island. And one of my most successful programs is, would you believe it, safe abortion in Bangladesh. The alim ulama never bothered with me. Of course, we call it menstrual regulation, but it really reduced maternal death by just having safe abortion. So that is the background given by Professor Yadav. The next one is the Associate Professor Safura from IMU. She will give you her experience in applying the social determinants of health in one of the clients that she sees in the clinics.
Thank you, thank you, Dr. Narimah, and a very good evening to all. So now, let me just try this. Yeah. Okay. So what I'm going to do is I'm going to take one component, and that is elderly health, and how do we look at social determinants of health within the context of elderly health, to give a focus and to understand how we relate to the one part of the population. So Prof. Yadav have already mentioned the various components of SDH, but just to reiterate, what is SDH, as per defined by Keating and Hertzman, is that the ways in which elements of the social, economic, and physical environment interact with the individual's biological factors and behaviors and shape their health status. So if you look at the figure here, now all these elements actually interact with each other, and in the context of the elderly, what I'm looking at and I would like to share with you is what are some of the key issues in elderly health in relation to the various components of the social determinants in health. And if you, the list that I have in front of you here is, among others, loneliness, of course. I'm sure you can relate to this, either your relatives or your siblings, your parents. So these are very common key issues: loneliness, coping physical challenges, medical problems, boredom, financial stresses, to name a few. I'm taking a few here. For instance, loneliness. And I think just to give you what are some of these components. In loneliness, there could be situational loneliness, and this is related to some unpleasant experiences, migration, or conflicts that they experiences. And then developmental loneliness, such as personal poverty, something that they have undergone with, or internal loneliness, something to do with low self-esteem or something within themselves. So as we have heard from Dr. Yadav, that this actually can lead to some pathological depression, immunological impairment, hospitalization, and even morbidity and mortality. Now the next one, for instance, social isolation. We can relate to this as well. To be not isolated, these are the key attributes. You must have belonging, engagement, fulfilling relationships and quality relationship and social context. And I'm sure lacking in all of this definitely leads to social isolation. And it can lead to issues with health behavior. It could be not practicing the right health practices, having psychological issues, physiological problems like having common cough and colds, and lack of exercise, physical issues related to social isolation. Now another area which is stereotyping, right? The community looks at the age with a certain slant. Either, of course, it could be an ambivalent. They have an ambivalent views of the age. It could be positive, right? They will say that the aged are wise, experienced, kind, matured. But on the other hand, more often than not, is they have a very negative view That is, they are grouchy, demented, incompetent, frail, name it. And this incontinent. And unfortunately, this sometimes results with being influenced by those comments, and it is increasing within themselves, so much so that it will influence their self-efficacy, and they may perform poorly, whether in memory or in their tasks, and they have role loss. And I think many more in the list. So what are we talking about? I mean, the whole list of things is something that is in front of us, and I don't think these are not unfamiliar to you. But what is important for us in the medical fraternity or the health fraternity is looking at the equity and ensuring healthy aging. Now, we heard about the causes of the causes, and here definitely we do realize how social exclusion, block opportunities, and unequal returns on effort will result to various causes that will affect some different consequences, differences in experiences and distribution patterns of inequity among the elderly. I'm just giving 2 examples here. For instance, healthcare for the elderly versus health resources offered to younger population. Now, for instance, definitely even in Malaysia now, we are seeing the gravitation of resources going for, particularly for the younger population, and we will dismiss the fact, it's just not cost effective or cost efficient to provide for the elderly. And I'm sure we all come from the same fraternity. We can see that quite overtly being done. So this intergenerational equity is there. And then we are talking about, for instance, like the B40 that is going to come. All right? It is definitely up to us now to make sure that such a situation does not exist. If the B40 is going to be opportunized by the younger population, how do we reach to the older population to ensure that they will benefit this? Or will there be an overwhelming response that, it's conveniently this, the need for looking at for the elderly will be just dismissed because it's just too difficult. Now, another situation is perhaps like certain group of elderly receiving disproportionate level of care. We call it, it's an issue of distributive equity, right? Some elderly who are more prone to go for healthcare, have more access to healthcare, all the resources are going to them. For those who are at home and difficult to access may be forgotten. So again, how much of effort are we looking into this? So what are supposedly the right social response? Now, healthy aging is aging with social justice. The functional abilities to be and do what an older person has reason to do. The World Health Report on Aging in 2015 has lined up a whole document on how we could address healthy aging. And I think most of us, particularly we are in the medical and health fraternity, we are very objective. Social ideas and social health is quite foreign to many of us because we just want, if we operate on this, we expect this to be treated. But social elements is quite foreign to many of us, and sometimes we refuse to also understand it because it's so complex. It's so it's so amorphous. So sometimes we feel that this sort of things is beyond our boundaries. So, but actually it is very important if we want to look at healthy aging and quality of life. So what are these functional abilities? It is the role identity, to have relationship, have possibility of autonomy, enjoyment, personal growth and security, to name a few. Now for a medical doctor, this is far-fetched. I just want to know how many patients has been treated, how many do not have complication of this operation, and to list a few. So these are the sort of things that actually we have to imbibe into our domain now. And what we want to achieve is an age-friendly world, which is capabilities approach, and therefore to make social conditions constitutive of functional abilities, to give that platform so that these functional abilities can be imputed into the plan of action or into the tasks or activities that we want to introduce. These are the hard facts. Today, around 2020, 1 in 18, every 18 person, there is one elderly. More than 65, not more than 60. I haven't reached 65. And in 2040, it is 1 in 8, right? In other words, for every 8 members of the population, 1 is an elderly. So the more that the various challenges we are going to face with. But what are the policies that have been in the news? To be frank with you, when I've gone through, it's actually quite dismal. There's not many, really. Of course, it's being said, priorities, policies for an aging population. I know that for the last 30 years, and I'm sure during Datuk Narimah's time, Datuk Raj Karim's time, we've already been looking, Dr. Yadav, into elderly plan of action, into issues of elderly. But, it's within the Ministry of Health. 3 more, is it? And it's not comprehensive. It's not doable. It's too expensive. It's just we're just targeting too small a population. We won't make a difference. And I think until today we are still struggling. What can be done really, objectively for the elderly? All right, looking at all the social determinants elements to put together. But of course, recently we have one good one, and that is the introduction of the law for the elderly. Okay. But what, it's actually not very clear here, but what is being mentioned in that press conference is, or the press statement is 3 big elements, and that is centers for nation, centers for the elderly, and the other one is collaborating with the United Nations on age-friendly city, which is good, and then of course looking at the contribution of workers age 60 and above. Now, we were hoping that when, at least I was hoping when a DPM make a statement like that, it will be a comprehensive coverage of what are the elements that must be included into the policies for the ages. And this must be continuously shared with the population and not just, snapshots of it. So what is required is back to the social model of health, the Dahlgren and Whitehead, which Dr. Yadav has shown you. And that is really not just looking at the infrastructure. We are talking about we're just talking about just the housing, transport, health, legal, employment, agriculture. This is a must. But how do we relate that? How do we relate that to the elderly who is supposed to benefit from all these elements put together from the social aspect? Now, I know time is running out. So, and in many other countries, we see a lot of work is being done, right? Particularly our friends in Australia, in New Zealand. But I think there are a lot more that must be done. And I'm just sharing you some of this from China, and these are 2 days ago. 2 days ago, news clipping. So. Before I end, I just want to quote Ferraro and Shi, which says that from life course perspective, diverse elders will be emotionally and physically healthier, and that's what we want, when they and their families make a living wage, earn, and have a decent and affordable housing and reside in a safe and healthy promoting neighborhoods in a society that values diversity. With that, ladies and gentlemen, food for thought. Thank you very much.
Thank you, Safura. I think you chose a very good group of healthcare user, the elderly. This morning we heard a lot about population aging. So if you look at being old is not great, being old and poor, that's terrible. But I don't know, I don't see empirical data being old and poor and a man as compared to being old and poor and a woman. Who fares better? Is it the man or the woman? I think that's where gender inequalities become rather dim. It's not there isn't much, I think, gender differential, but I haven't seen much empirical data. So thanks, Safura. Our next speaker, Natasha, as I told you, she works for an entity called Doctor to You, very interesting. and she will talk to us about how to leverage care, the care teams that people who give care, to improve the social conditions of patients. So Natasha, Miss Natasha Francis. She's, by the way, the Business Development Executive in the outfit called Doctor to You.
Thank you very much, Datuk Dr. Narimah. And thank you to the organizers for inviting a humble startup such as ourselves, Doctor to You, to provide our perspective. I know it's the end of the session and I'm the last speaker, but I believe we'll be providing a very fresh perspective of the healthcare system and how to move away from the traditional healthcare model. Okay, so I'd like to start off by saying that the healthcare industry, especially the private sector, I believe, has been focusing on moving towards quality care and preventive healthcare. And this has brought a lot of attention to social determinants of health, right? Every dollar we spend in preventive healthcare can actually save millions of dollars in the future in actual, inpatient treatment and outpatient treatment as well. So I won't be going into too much details of the social determinants of health because our previous, my fellow speakers have touched on it. And I'll be focusing more on the solution and how we can actually try and solve these problems. So let me just touch a few of the social determinants of health. The first would be accessibility, and this could be due to geographical constraints. Some people might be in rural areas, some might be in urban areas, especially our friends in Sabah and Sarawak. They may have constraints due to having to cross rivers, having thick jungles, and it's very difficult to get healthcare to their locations. Second problem would be transportation options. This in particular, I think, would affect the elderly because they cannot bring themselves to their appointments. They might not be able to use public transportation as well. But I'd like to highlight actually an initiative that is started in the US by Uber. They actually have a new vertical called Uber Health, and they are working with the hospitals there to provide transportation for elderly to arrive at their appointments on time. So the hospital set the appointments, and Uber would just send them an SMS reminder the night before saying, you have an appointment tomorrow and please be ready at so-and-so time and your car will be waiting for you. That's it. You don't even have to download the app. So I think these are things that we can explore within Malaysia as well. And I don't know if many people here know, but Grab in Malaysia is actually working with the Ministry of Health, and they provide vast discounts to users to actually use Grab to go to all the Ministry of Health locations, including HKL and many more. The third issue would be fragmented ecosystem. And I think this is a very big issue. Our neighboring countries such as Singapore, Australia, they have all moved towards solving this issue by having integrated health data platforms. In Malaysia, both the private and the public sector are they work in silos, and data is not being transferred between organizations, and this in return affects the patients very drastically. They may not get accurate diagnosis because the doctors do not have the historical health data of the patients. Another issue would be surrounding physical factors. As mentioned previously, the physical condition of a person is not the only factor that affects their health. We also have to look at their workplace, whether they are exposed to chemicals, their homes, whether they are living near construction sites, and so on. The fifth issue would be healthy behaviors. We also have to look at their diet, whether they are practicing exercise, and whether they are abusing alcohol or drugs, and whether they are practicing safe sex, and so on. And finally, the economic status. I won't go into too much detail as it's been spoken about previously, but I'd just like to touch again on this. Actually, it's been said in the third session. We actually spent 50.3 billion ringgit for our for our healthcare expenditure in Malaysia in 2017, and that is 4.4% of our GDP. So in the public sector, 90% of this cost was actually absorbed by the government. So patients had to fork out about 10%. But in the private sector, we are still paying about 39% out of our own pocket, meaning it's not covered by the insurance. And that is quite a significant amount. So we do need to help those who are less fortunate, who are not earning as much, and they may not be able to fork out this fund. So we do need to think of innovative ways to reduce costs while improving efficiency. So how do we actually tackle this issue? How do we provide relevant solutions to the right segments? And I believe the key to all of this is data. We first of all need to collect sufficient data, and the data needs to be continuous data, meaning we should have a profile of every single person from cradle to grave. And it shouldn't just be health data, it should also include other factors of their life, such as education, whether they've had health education, whether they've had sex education. We should also look at things like whether they've been vaccinated, and many other relevant data. So all this data needs to be consolidated from different user touch points, and this will help provide insight into patients' behavior and their demands and their consumption. Okay, and in this way we can improve operational effectiveness and the outcomes, and definitely provide more accurate diagnosis. Okay, so moving into the solution, as I'm sure you can see throughout my slides, I believe that technology is the way forward. This is how we are going to improve the lives of our fellow Malaysians in terms of health. And this was actually brought up by our Minister of Health. He did mention that digital health is a powerful tool in revolutionizing non-communicable disease care. And this will empower patients to take control of their diseases and be able to manage their own health. Okay, so just to share a little bit about health tech space in globally. First, we'll look at the US. One example would be Apple Health, right? Actually, beyond Apple Health, everybody's smartphone now has tracking, right? You get to track your steps, track your pulse rates, key in your sleep times, key in your diet. All these are important data, but this data is not being passed on to healthcare providers, which could actually help them provide better diagnosis, could provide better treatment plans, and so on. So the second health tech trend I would like to point out is Babylon. And this is in the UK. They are actually providing artificial intelligence. It's a chatbot that has used data from the NHS to provide suggestions and treatment plans to patients just by having a chat. It's like WhatsApp. Okay? And another example would be Grab. Other than the initiatives I mentioned earlier, they are also looking to start a new vertical in the healthcare space where they partner Pinggan Good Doctor to provide on-demand healthcare services in Southeast Asia. Okay, so how do we bridge the health inequality gap? So these are a few key points that we should look at. The first is patient-centered service. We should provide more personalized, relevant service and testing for patients instead of general tests. And all this can only be done if we have the second point, which is integrated data platform. You need to know the full health history of the person to provide personalized services. And third is holistic care. Like I mentioned earlier, we need to look beyond just the physical health. There are other aspects of the patient's life to look at, which I think can be solved through on-demand healthcare, and I'll share a little more through our experience later. The fourth is constant engagement with patients. So right now, I believe You would go to a hospital, you seek treatment, maybe you need to be admitted, but what happens after you have been discharged? You have to wait for your next appointment to receive consultation. What about in between? Are you tracking your progress? Are there any follow-up from your doctor? What if you have any questions? These are some points that we should look to improve. And last of all would be improve accessibility and communication. Healthcare should be available at any location and at any time. And this can only be done through technology because it's impossible to place a healthcare professional at every location. Okay, so this is a brief snapshot of what Dr. To You does. We provide healthcare to your location, telemedicine, electronic medical health records, systems and softwares to healthcare organizations, and an e-commerce platform. So looking at healthcare to your location, for home care services, for example, yeah, you can see it, okay. I believe this will help because the doctors actually gets to go to the patient's home and he might pick up different causes for the diseases that could not be picked up at the clinic. For example, the cooking materials that they use. What if he's using a rusty pan to eat? That could be the cause for the disease, but you wouldn't be able to see that if you were at the hospital, right? So, and the second issue that it's solving is transportation, of course, because the doctor is now coming to the patient's location. Okay. The second service, medication delivery, again solving the issue of transportation because medication is being delivered to you. And I think it also promotes adherence to disease management as they will be provided with reminders to consume their medication and reminders to refill their medication on a monthly basis. Okay, for telemedicine, we do provide live chat and video consultation, and this is especially useful for follow-up consultations, especially after surgery. And the good thing is, I think most of us, when we go to a doctor's consultation, we don't actually remember everything that the doctor said. It's good that through the live chat, everything is transcribed and you get to refer to it again. And if you have questions after a while, you can even ask the doctor again. Right? And this, of course, is vastly cheaper than going to see a doctor physically. Okay. Next is electronic medical records. This is what I mentioned earlier about having integrated data platforms to have a patient's historical health data on one platform from cradle to grave. And I hope that this will be integrated in Malaysia in the coming years because it's very useful. You can avoid repeat tests. I'm sure a lot of people have experienced this, where you go to one hospital and you did a blood test, an X-ray, and when you want a second opinion, you go to another location and you have to do the test all over again, which is really a waste of time and money. Okay, and of course, with having your health data online, it's important to keep it secure. So at Dr. To You, we ensure all data is encrypted through our partnership with Microsoft, and we actually allow patients to lock their medical records using facial recognition and Touch ID. Okay, some other features that we have include ambulance service, okay, and e-commerce, where you can purchase healthcare-related products and services. And I believe this will incentivize people to take more initiative in managing their own healthcare and preventing it from becoming a life-threatening disease. Okay, and finally, of course, systems and softwares. It's important that not only we collect data from patients, but we need data from healthcare organizations so that the data is holistic and complete and can provide suggestions, relevant suggestions. Okay, this is the last slide, I promise. For after healthcare, on-demand healthcare, the next stage is, of course, to leverage data, and there's a lot of devices available out there, and it should be integrated with the systems and softwares so that we can enhance tracking as well, such as your glucose tracking, heart rate, and BP tracking, and so on. Okay, that's it from me. Thank you very much.
Thank you, Natasha. Thank you for describing to us a real application in the commercial sector. A very, very interesting product, if I may call it. Ladies and gentlemen, now is the Q&A time. We are supposed to finish at 4:30, so we can extend maybe 15 to 20 minutes. But I would appreciate it very much if you can be at the microphone for not more than 2 minutes to ask relevant questions. Is there anybody who wants to make comments or ask questions? Yes, yeah, please. Introduce yourself and who you represent. The lady first, then Dr. Lim. Shall I care for the elderly first? Okay, never mind. You're at the mic already. No, you're at the mic already.
I'm Jade from the Galen Center for
Gender
Health and
Before Age.
Social Policy. So my question is directed to the panelists. As we are talking about social determinants of health, what are the panelists' thoughts about introducing universal social protection schemes in affecting health? Universal social protection schemes, and how this would affect the social determinants of health.
Universal social protection scheme, okay.
Welfare schemes. Thank you.
Okay, Dr. Lim, you wanted to ask a question?
Is that when you talk about social determinant of health, you look at our mortality rate, especially premature mortality rate, which is quite high in Malaysia, premature mortality rate, especially in the underserved areas, you notice that a lot are caused by social determinants. And we can talk till the cows come home. It will not work unless there is political will. At least at cabinet level, you have one in a cabinet level on social determinants of health to address all the problems, because a lot of things are in other ministries and they have got their own priorities. If you don't have this type of thing, and of course, we must not forget WHO's advice to us, HIAP, health in all policies. If you cannot get at least Ministry of Health to comment for other ministries' action, we'll go nowhere.
Yeah, before the panelists answers the first question, I would really like to reiterate what Dr. Lim has just said. I think one of the most difficult things that we try to do, Dr. Raj is no more here, Yadav, Safura, myself, is really trying to get this effective, smart partnership that makes the other agencies, the other sectors look at health with a priority. I think that is something that we have not succeeded very much. So health in all policies has not been a great success in this country, in Malaysia. Safura, would you like to answer the first, Yadav, anyone? That was about universal health protection.
Yeah. Regarding the universal health protection depends, I'm not sure which, are you driving into towards financial protection? Social protection.
Are you talking about insurance, not financial?
You're talking about the social sector, how can you clarify a little bit? I mean, maybe.
So basically, for social determinants, there are many, as the panelists pointed out, there are many determinants to health, like, say, poverty. So you have, like, say, take the UK, they have a system called universal credit. So it's a welfare system in which they provide financial protections to people who are in vulnerable communities, like, say, single mothers, people in poverty, so on and so forth. So I would just like to know the panelists' thoughts about how such protection schemes and how it will be relevant in the area of healthcare.
I think, again, you're going back to financial protection, right?
It's like the BSH, the Bantuan Sara Hidup.
Actually, not really. I think you're trying to equate the system like in UK, where you have the social sector. I mean, the government taking care of all the needs of the individual when they go. And elderly especially. If you get a handicap, then they come and help you in the house, and they send a nurse to the house and all that. That aspect of, I think, social protection in the Western countries is, I think, very developed as compared to here. We are actually doing social welfare, but not getting into that detail which I think you are expecting in terms of that. But that's an area which I think we need to work on. Really, we need to work on helping people in handicap. I still remember a teacher of mine who actually, had a stroke. And then the next thing is the welfare system in UK came and readjusted the house for him to use the toilets and going upstairs and things like that. Now that aspect is covered under their scheme, but we don't have that scheme. I think we need to work on that.
If I can just add, usually in those countries they already have this what they call as long-term care. And that contribution usually starts even, when every parts of the population start contributing at the moment they are employed. So, when the time requires, those kind of budget is already made for it. And it's not available yet in Malaysia.
Yeah. And looking at the elderly, a very, very good model is in Australia for that. You would have prepaid for it. So there are, and I think what Prof. Yadav says is true, to respond to your question. There are many theoretical things, as Safara has put that, for the elderly. You need recreation, you need employment, you need safety from robbery in your house, being attacked, all those kind of things. But there has been no cohesive, single government program to do that. And I think there's something that we can make a recommendation on. Any other comments or questions? Okay. Either you understood everything so well, or you're so blurred that you're very tired and you really want to go home. So I would like to thank my three panelists for giving us a very, very good insight into the personal experiences in handling social determinants of health. And I would like to thank the audience as well, who have the resilience to stay until 5 o'clock in the evening. Thank you very much.